This is Michael Kieran. I'm going to be talking to you about the reduction of emergency room usage, primarily focusing on IV-related issues such as soft tissue-related infections. This is primarily a form of public health education out in the community. It's how we can help reduce everything. So first, we have our problem. One out of every four patients that are admitted into the emergency room on average suffer from some form of IV-related injury, overdose, or soft tissue infection from unsafe injection practices. In 2015, Jackson Memorial Hospital reported that over a 12-month time period, the average cost spent on the drug use-related infection toppled roughly $11.4 million. This is just one facility. That's a lot of money for one hospital, and this is a epidemic happening worldwide. This is not just like overdose or anything. This was just focusing on infection alone. So those soft tissue infections, which make up most of the emergency room occurrences. I have my PICO question here. The population is the emergency room in specific. We're trying to reduce the amount of patients who use the emergency room. Implementation of mobile clinics in high-risk areas with low social and economic status, wherever it's the most prevalent, that's where we find these things. I want to compare it to other facilities that are currently implementing this program, and I want to compare it to other studies that are currently using these programs. The outcome is to identify which strategy helped reduce or increase the emergency room visits, how many of these there are, what kind of barriers we have to overcome, and just questions that come to your mind. The prevalence. More and more individuals are working nowadays, and the insurance that they are provided is not sufficient for the amount of pay somebody would get when they go to the emergency room. Due to the influx of the working class, people working one or two jobs just to get by, people tend not to take days off. So when people get hurt or harmed, they tend not to go to the urgent care. They tend not to go to their primary care physician, and that's because they can't afford to take those days off. They might have kids, bills, etc. On top of the co-pays that they might have to pay out of pocket, which some people can't afford, which can push people into debt or some form of bankruptcy. So these individuals, like you and I, tend to put these injuries off until eventually it becomes so painful or so much discomfort that they can't work. They can't even get up in the morning. So they call emergency medical services, they get admitted to the emergency room, and they go through that process. Same thing happens for individuals who use IV drug use or opioids. The only time they usually go to the ER is for a few reasons. One, because they have a bad infection, they don't know what's going on, they need emergency help. Two, they're just looking to get some drugs, get their high, and leave. And three, they are overdosing and they need some emergency help. So a study from 1997 to 2007 showed that the increase in emergency room increased roughly about 350 to 390 persons per 1,000 on average. So basically what this means is every 1,000 people they were seeing about a 35 to 40% increase between that 10-year period. Now this is a little older study, but trending wise it has increased. I have a few articles of review. These are the ones that I found through my research to be the most prevalent and the most informative. One is about the impact of needle exchange-based health services on emergency department usage, changes in injection practices associated with the use of medically supervised, like a safe injection site, and then the harm reduction in hospitals. Interventions for these would be a few interventions on top of public education. We got the safe needle injection sites with highly trained medical staff personnel on hand to help educate these persons. We have a mobile health clinic for high incident areas and to hit and reach critical access areas where people may not be able to access normally, and free needle exchange sites so somebody can turn in their dirty needles for clean ones to help get that stuff off the street. Few of these practices can be seen in our community or around the country, if not in our own backyards. However, it doesn't mean they are working properly, and I'm here to explain how these programs work, the benefits of these programs, and how we can improve upon them. So the first thing I have is the impact of the needle exchange based health services on emergency department use. So, a free needle exchange have shown to allow opportunities for medical services to reach the demographics of IV drug users. These programs allow us to directly impact the rates of bloodborne pathogen transmission by reducing the amount of shared needles on the streets, providing individuals with cleaner needles for a more safe practice. So we're eliminating dirty needles being used. So we're right off the back, we're eliminating potential infections. We're eliminating potential hepatitis transmission, endocarditis disease. And other bloodborne pathogens such as HIV/AIDS, which in the long run saves facilities a lot of money, and the public health a lot of money. Changes in injection practices. So this article was basically talking about how we should use more safe injection sites, allowing individuals to come to a facility and inject themselves with IV drugs, but under supervision of trained medical personnel. So what this means is people will come into these sites. We'll set them up with sterile supplies. If they don't know how to inject IV, we will teach them the proper way so they can take that home with them, such as like bevel down and proper use of tourniquets, proper use of sterilization agents such as waters and stuff when people cut their drugs, etc. And this study has showed that roughly 27% of the emergency room usage was decreased. So that's a quarter of the population. So that's a really big number if you think about it. So you get 1,000 patients, that's 250 patients that are no longer going to the emergency room. That not only allows us to properly staff the emergency room, that allows us the hospital to save money for out-of-pocket expenses and etc. Another idea behind a safe injection site is to provide individuals with the means and opportunity to develop and carry out a treatment plan. So what I mean by this is that we have individuals on site that are properly trained, how to treat, how to assess, etc. We have physicians that can prescribe. So these safe injection sites allow individuals for when they get comfortable to better their lives by creating a treatment plan and start to following it. Not every IV drug user is just trying to get high every day. They have a bad stigma, and people need to understand that. The third and last article I looked at was harm reductions in hospital. IV drug users often leave against medical advice. This article was focusing on all the reasons why they leave, and due to them leaving, they usually are readmitted later. Could be a few days, could be weeks. This article was kind of vague, but basically it determined that it could be a multitude of things. It could be from feeling like an outcast being judged. It could be from people just wanting to get their high and leaving right off the back, or these individuals thinking that the hospitals are actually going to contact authorities and try to get them incarcerated or something, which is against HIPAA, of course, anyway. So this is talking about creating a system that works best for the individual, something that's non-judgmental, getting the staff on board, educating the staff, educating the patient on proper treatment plans, reduction of infection, and advocating for needle-related programs. This article actually looked at 32 other articles. It wasn't a hands-on research project. Instead, it just took in consideration previous research that was done. So going over all these articles, the needle exchange-based program, this article, although it was a little out of date, the information was still prevalent today with the increase of incidents and occurrence that we see nationwide and worldwide. The information that I gathered through this determined that everything was questionnaire based, so people were just handed a survey. So as we all know, surveys can be very reliable in terms of gathering quick information, but I don't think that they're 100% accurate. I mean, we've all taken surveys. Some people just like to fill them out, get them done. Some people might take this seriously, though, so it just gives you a quick, down and gritty representation of that area. I wouldn't say it's the most accurate information, but it's a good amount of information to determine what's going on in that area. This study was also looking at the incidence rates of IV drug users and how to reduce bloodborne pathogen occurrence and transmission. This was not looking at how to decrease emergency room usage. That was just one thing that it discovered. They actually discovered that if we decreased the amount of dirty needles out there or used needles, it actually indirectly reduces the amount of people going to the emergency room. So this study is not the most accurate in terms, but it was just I thought it was a good representation that if we treat a primary cause, so we know needles cause skin infections, we know needles can cause bloodborne pathogens or endocarditis if used inappropriately. If we can treat that, we can completely eliminate the need to even show up to the emergency room. Now, the next article was the safe injection practices. I thought this was the most useful and article, had the most prevalent data, the most something that I would like to carry out on a hospital. So this article focused on decreasing the actual emergency room usage by creating a program out in the public, treating these issues right at the source. These issues that were addressed are soft tissue-related infections, disease transmission through needles, overdosing, and sex trade-related incidents. So people think, how does sex trade relate to this? So some individuals actually perform sexual acts to get high or for money so they can get their drugs. So that's what I mean by this. This article also used a questionnaire, which I previously mentioned isn't the most accurate, but how they did their questionnaire was they gave it the first day that they came in, and then they followed these individuals for 6 months. So if these individuals met the criteria and they kept coming back, they were given another questionnaire after 6 months. And what we noticed in the study that there were 760 participants, and out of that 760, 433 of them were still practicing these safe injections. They were practicing at home and they were coming back. So that's a huge percent. That's about 54% of these patients. Over half of them were coming back and using safe practices, which helps, of course, treat this issue at the source, making sure everything's clean. And another huge thing that I discovered was there was a 27% decrease in emergency room uses just from safe needle injection sites. Now these sites are open 24/7. They have adequate staff, all that I mentioned earlier. The surveys, again, are not the most accurate information, but the information in the is there telling us it's 27% decrease in the emergency room, and there's 54% of all patients who use this site are coming back to use it, not only because they feel safe there, but they know that they're injecting safely as well. And these insights also showed they had a positive impact on the individuals' lives. And what I mean by that is these individuals were beginning to ask for more help. They were following their treatment plans. They were practicing safe injection at home, teaching their friends how to do it. They were reusing less and less of the syringes. They increased the use of sterilization, such as boiling their water and mixing it with their agents, etc. Now, the harm reduction in hospital, I thought this study wasn't the most accurate. It was kind of vague in terms of what's going on. It was focusing on why patients leave AMA, which is very important for terms of readmission, because most hospitals eat that cost if they come in for the same exact problem that wasn't treated. But it just went over multiple studies. It was 32 studies. The information was very accurate, but it was just jumping around too much. It was asking why these patients go AMA, and then talking about maybe it's because they don't feel comfortable there, maybe it's because they were just trying to get high, maybe they just left because of anger. It was just very confusing. But this study wasn't on hand. It was just taking consideration multiple studies. So when we take in consideration of multiple studies, I think there was a little too much information because it focused on methadone clinics, safe injection sites, focused on needle exchanges, and just the overall emergency room usage. So it was kind of overwhelming and it jumped around a little too much. However, the information was still there that if we treat these patients and we find out why they go AMA, we can treat that at the source, and then we can prevent these people from leaving against medical advice, and we can keep them in the facility longer, or maybe get them on a proper treatment plan, get them on some methadone or something, and help treat them out in public. So overall critiquing, all these articles did determine community outreach programs for the facilities greatly reduce emergency room usage and occurrence. Some articles are very informative, while others were indirect, such as the AMA article that I discussed. The data that I collected, although it was a small scale, it's a really good representation of what's going on in our community. All the articles agree that the prevention of infection and reusage of needles is the best preventative measure in terms of decreasing the emergency room occurrences, indirectly or directly. And reducing ER usage can save monies on out-of-pocket spending, save hospitals money, and safe injection sites are determined to be the most beneficial aspect of a primary form of treatment. Now, things that I would adjust and change, although I have researched some to be very effective and few aspects in which I believe can be improved upon, I believe that a mending of all these programs into one is the most important preventative measure, basically creating one hybrid system. Creating a mobile safe injection site is the overall goal. So a safe injection site and a mobile clinic, if they came together and we could drive into a critical access area or an area of the highest incidence, we could better treat that population. This allows us to more effectively treat the issue on hand, disposing of all the used needles that are in these prevalent areas, providing a safe site for injections while educating these patients on how to sterilize their own equipment and provide the opportunity to start a treatment plan. I also believe that we have to have methadone maintenance or some form of PO medication maintenance for their disease process, because although IV and safe injection sites are very beneficial, overall the goal is to get them off injecting. Okay, so I believe that these methadone clinics need to be incorporated into this program as well, or some form of PO, so we can regulate that opioid usage and give patients the opportunity to take their medication by mouth, so we can completely eliminate the injection portion, which would completely eliminate the soft tissue related infections that, of course, are the number one reason for emergency room visits. On top of all that, I also believe that site consults need to be incorporated into this, because it is a known fact that it is more likely for somebody who has been through some form of sexual trauma, physical abuse, or neglect as a child, or any kind of trauma, PTSD. It is a known fact that they are more likely to turn to drugs, either suppress their emotions or suppress their pain from the past. So if we can get them in some kind of psychotherapy, maybe some group therapy, to kind of talk about what's going on and face those issues at hand, maybe that could even help decrease the incidence of drug use or IV drug use. But those would have to be looked into at another time. And then I have my references, of course. And thank you so much for listening. I hope this helped inform you about how to better reduce our infection rates and our emergency room usages. I mean, although the beginning, it is a start and something that I would love to keep pursuing. Thank you.